Internists occupy a unique role in healthcare. They are experts in a spectrum of diseases and complex illness, earning the moniker, the doctor's doctor. Internists use their vast knowledge, experience, and skill to identify the best possible treatment strategies, making them scientific puzzle solvers. They are proponents of extensive clinical research, evidence-based medicine, and continuing education, fueled by the commitment to provide high-value patient care that balances science and compassion. In 2023, the Philippine College of Physicians celebrates 70 years of excellence and service above game. Driven by passion, constancy of purpose, and prudence in internal medicine. Take part in the 53rd Annual Congress of the Philippine College of Physicians on May 7 to 10, 2023 at the Philippine International Convention Center. Together, let's revisit all that we've become and move toward all that we can be. Internists occupy a unique role in healthcare. They are experts in a spectrum of diseases and complex illness, earning the moniker, the doctor's doctor. Internists use their vast knowledge, experience, and skill to identify the best possible treatment strategies, making them scientific puzzle solvers. They are proponents of extensive clinical research, evidence-based medicine, and continuing education. Fueled by the commitment to provide high-value patient care that balances science and compassion. In 2023, the Philippine College of Physicians celebrates 70 years of excellence and service above game. Driven by passion, constancy of purpose, and prudence in internal medicine. Take part in the 53rd Annual Congress of the Philippine College of Physicians on May 7 to 10, 2023 at the Philippine International Convention Center. Together, let's revisit all that we've become and move toward all that we can be. Iba na kasi ang panahon ngayon. Pakiramdam mo, naglalakad kang pauwi ng hating gabi at kinakabahan ka. Yun bang kahit anong ingat mo, anytime, pwede kang matiyempuhan ng masasamang loob.
Tuwing lalabas ka ng bahay, ang dami mong iniisip na pwedeng mangyari. Para bang nasa gitna ka ng dilim. At nagdarasal ka na lang na sana may proprotekta sa'yo kung sakasakali.
Ang pandemya ay parang isang iskinita na kailangang daanan. Alam mong may nagtatago sa dilim, pero wala kang nakikita. Puno ka lagi ng pangamba. Pero may liwanag na naghihintay. May proteksyon laban sa COVID-19. May maaasahan kang backup. It's time to vac up. Oras na para magpa-COVID-19 vaccine booster for backup protection, control, and prevention. Para sa mga 5 taong gulang at pataas, eligible na kayo para sa first booster shot kung nakumpleto nyo na ang inyong vaccine primary series. If you are a senior citizen or a frontline health worker who is 18 years old or above and have completed your first booster, you are eligible for a second booster shot ayon sa Philippine Department of Health. Ang COVID-19 vaccine boosters ay nagbibigay ng karagdagang proteksyon na maaaring humina na ang bisa mula ng inyong huling vaccination. Booster shots are effective in helping prevent serious illness, hospitalization, and even death. So, stay up to date with your COVID-19 vaccination. Kasama na dito ang booster shots. Magtanong sa inyong doktor o barangay clinic kung ano ang naaangkop na COVID-19 vaccine at tamang panahon para sa inyo. Sabay-sabay nating lakbayin ang daang patungo sa malusog, malakas at magandang kinabukasan. Protect yourself and your loved ones. Help control and prevent the spread of COVID-19. It's time to vac up. Internists occupy a unique role in healthcare. They are experts in a spectrum of diseases and complex illness, earning the moniker the doctor's doctor. Internists use their vast knowledge, experience, and skill to identify the best possible treatment strategies, making them scientific puzzle solvers. They are proponents of extensive clinical research, evidence-based medicine, and continuing education, fueled by the commitment to provide high-value patient care that balances science and compassion. In 2023, the Philippine College of Physicians celebrates 70 years of excellence and service above game. Driven by passion, constancy of purpose, and prudence in internal medicine. Take part in the 53rd Annual Congress of the Philippine College of Physicians on May 7 to 10, 2023 at the Philippine International Convention Center. Together, let's revisit all that we've become and move toward all that we can be.
Let us put ourselves in the holy presence of our Lord. Our dearest Heavenly Father, thank you for making all things possible. We are grateful for all the blessings you are pouring upon each one of us, despite the challenges we are all currently facing. Thank you for blessing us today with the wonderful opportunity to meet virtually and learn together in the awesomely exciting webinar. May your blessings of wisdom and guidance be upon us, all through the sharing and impartation of knowledge and skills by our resource speakers, facilitators, and moderators. May all of us learn together, upgrade our competencies, and capacitate us to be the help in the development of our learners' lives and communities in the spirit of your love and generosity. May we now humbly commit every part of this webinar to you as we all bring you the glory, honor, and praises for your kingdom and holy name's sake. All this we pray in the precious name of our Lord and Savior Jesus Christ. Amen.
Through the dreadful darkness, we shall be the light and lead a path to wisdom. Our will to be our lives. To those in pain and suffering, we shall hear a call. With arms to care and comfort, compassion above all, to praise the brighter future, bound in unity, the Philippine College of Physicians, we shall be. Hand in hand, building a stronger nation, peace in
Good afternoon, everyone. Welcome once again to this afternoon's Philippine College of Physicians Health Forum. I am Dr. Lilibel L. Ramos Salamanca, President of the PCP Central Luzon Chapter, and together with Dr. Marjorie Rose F. Bravo, I will be moderating today's Health Forum. Welcome to our colleagues, the PCP members, healthcare workers, and our media partners. This afternoon's Health Forum is a collaborative effort of the Philippine College of Physicians, the Philippine College of Hematology and Transfusion Medicine, and the PCP chapters. Our Health Forum today is entitled Transfusion Medicine 101, From Donor Screening to Policy Making. Transfusion medicine is a discipline that encompasses the different aspects of blood banking, from donor screening, blood collection, and blood component storage, to compatibility testing and ensuring safety of the blood components. To give us the welcome message for this afternoon's Health Forum, may I introduce to you our incumbent regent for PCP Northern Luzon Region, Dr. Danilo F. Baldemore. Doctor?
Thank you, Dr. Lilibel, for that kind introduction. So magandang hapon po sa ating lahat. Nagpapasalamat muna ako sa ating mga bisita, sa ating mga guests, mga pasyente, sa ating mga PCP colleagues at partners in media for attending this Health Forum. So this is a part of the Committee on Advocacy in partnership with the Philippine College of Hematology and Transfusion Medicine. So napakagandang partners nito, kasama rin po natin yung tatlong PCP chapter na tumulong para mabuo itong ating Health Forum. So salamat po sa PCP Central Luzon, sa PCP Marikina chapter, sa PCP Western Mindanao chapter, at sa ating mga speakers for taking their time out para matulungan po tayo dito. Ngayon, isang tanong lang din ang gusto kong iwan sa inyo. Natanong niyo na ba sa sarili niyo kung pwede ka bang maging donor ng dugo? Okay? So ako, natutuwa ako at pinagmamalaki ko. Ito po. Yan. Nakikita niyo po yan. Isa na po akong blood galloner. Ibig sabihin, mahigit 7 beses na akong nagdo-donate ng blood. So pag nag-donate kayo ng ganyan kadami, magkakaroon kayo ng ganito kagandang pin. Okay? Pero hindi po ako matatapos dito kasi tuloy-tuloy pa rin yung pagtulong natin sa mga pasyente natin kasi naniniwala ako that blood saves lives and it's sometimes very difficult to get one when you need one. So again, welcome on behalf of the PCP President, Dr. Diana Payawal, and the PCP Board of Regents and the Chair for the PCP Advocacy Committee, Dr. Agnes Cruz. Welcome po sa inyong lahat. Thank you.
Thank you so much, Dr. Baldemore, for that heartwarming message and for formally opening our session this afternoon. I am Dr. Marjorie Rose Bravo. I'm the Present Vice President of the Philippine College of Physicians, Marikina chapter, as well as a member of the Philippine College of Hematology and Transfusion Medicine. And I will be moderating this forum together with Dr. Ramos Salamanca. So some house rules, we will be asking everybody to keep yourselves muted while our lectures are ongoing. If you do have any questions, we will entertain all of the questions for all 3 lectures at the end. So if you have a pressing question, or if you don't want to forget your question, you may always type your questions in the chat box, and we will take note of them and we will address all of them at the end. So without further ado, let's move on to our first lecture of the afternoon. It is my pleasure to introduce Dr. Rico Paulo Gomez T. He finished his Doctor of Medicine, his residency in internal medicine, as well as his fellowship in hematology at the UPPGH. So he is very much really with PGH. No? So he is currently a consultant in internal medicine and hematology in several hospitals, including the Premier Medical Center, UHBI Parañaque Doctors Hospital, Las Piñas Doctors Hospital, Manila Medical Center Manila, Allied Care Experts Medical Center, as well as the Medical Center Muntinlupa. Presently, he is also a medical specialist too, part-time at the Las Piñas General Hospital, and is a member of the Hospital Blood Transfusion Committee, and is also the assistant chair of the Hospital Research Committee. So let us all welcome Dr. Rico Paulo Gomez T. for the first lecture of the afternoon.
Good day. For this session, we will be talking about the blood donor and their eligibility to donate blood. We know that blood is a very important resource and we use it in our armamentarium of therapeutics. It increases oxygen carrying capacity, especially in patients who have anemia. It can replace volume and prevent hemodynamic instability, especially in cases of acute blood loss and hypovolemic shock, and also can supply clotting factors and platelets, especially for those who are bleeding. However, remember that blood is a finite resource. Our blood census is not always that high, and it is of importance that we have a good amount of blood for use for our very needy patients. And that is why it's important for us to encourage blood donation. For every blood transaction, there are 2 parties involved, the donor and the recipient. And it is an overarching importance that this particular unit is safely derived from the donor, and safe for use of the recipient. The blood unit should be safe from disease so that it does not harm the patient, and we should collect it in a manner that is safe, that is out of danger for our donors. So what happens when you as a clinician requests for blood? So first, how do we get blood units? The donor goes in to the blood collecting unit where they answer a questionnaire and a doctor performs a history and physical exam. Then afterwards, if they are deemed able to donate blood, the blood is extracted from them and it undergoes serologic testing for transfusion transmissible infections. Then the blood in the blood bank is separated into different components and are stored. Now, you as the clinician would then request for the particular blood unit. You decide which particular unit you would be using. And then the blood bank will perform compatibility testing before it is sent back to the patient for transfusion with monitoring. So back to the question, who can donate blood? Well, actually, anyone can donate blood. Anyone who is, first, a volunteer donor, and also a healthy donor. So who among these do you think is the best blood donor? Is it your family members, your son, your daughter, your siblings, or your parents, or a random person in a blood drive? Well, believe it or not, it's actually the random person who donates altruistically in a blood drive who is the best blood donor. because we are not coercing them to donate, because they're not getting anything really in return from this blood donation, and they don't have any ulterior motive to hide anything from donating blood, which makes them a good and the best blood donor. Based on the World Health Organization, the voluntary non-remunerated blood donor is the safest source of blood and is also the preferred source for blood transfusion. Blood and blood products coming from paid donors, they're not acceptable. And we say that a donation is voluntary and non-remunerated if the person gives the blood and blood product out of his or her own free will and they do not receive any payment for it. So as a general requirement, a donor should be at least aged 16 to 60 years old. If the donor is 16 to 70 years old, then we would have to ask for a waiver from the parents or assent. And for those who are older than 60 years old, especially if it is their first time donating, an assessment by a physician should be done first. However, for those who are over 60 and who have been irregularly donating blood, they can waive this requirement. Any blood type is acceptable for blood donation. We do not choose all gender requirement. Both males and females are eligible to donate blood. The donor, however, should at least be 50 kilograms because the amount of or the blood volume that we are getting might cause hypovolemia if the donor weighs less than 50 kilograms. And also, the last donation should at least be 12 weeks ago if the donor donated whole blood, or 7 days ago if the donor donated apheresed platelets. The donor should generally be in good health. They should feel fine during the donation. So it depends on their answers from the donor interview that the technologist does when they're donating blood, and also the questionnaire that they answer when they donate blood. And it also depends on their appearance and the cursory survey and physical exam that the physician does before donating. They should have stable vital signs, heart rate of 60 to 100. Blood pressure should be less than 160 over 100 millimeters mercury. And the hemoglobin for males should be around 135 to 185 milligrams per deciliter. And for females, around 125 to 175 milligrams per deciliter. So this is an example of the blood donor history questionnaire. So it's quite long, but it checks for the health status of the donor. It would also check for medications that the donor might be taking, which can affect the quality of the donated blood, and also checks for certain high-risk behaviors and histories which might preclude them from donating blood. So let's try to answer some questions which you might have encountered your patients asking you if they or their significant others would be donating blood. First question, what if you're sick? What if you've got cough, colds? Will you be able to donate? So again, the overarching tenet for blood donation is that the donor should be feeling well, should be okay before they donate blood. If they are not feeling well, if they have fever or are taking an antibiotic, then they should not donate. They would be deferred temporarily. However, if the patient feels well enough, even if they've got minor cough or colds or they've got allergies, then they may donate blood, again, as long as they're feeling well enough to donate. However, if the cause of these symptoms are infectious in nature, if they've got bacterial pharyngitis or if they've got a viral infection going on, then they would have to wait at least 1 week after resolution of symptoms before they can donate blood. So every when can donors donate? So they can donate 12 weeks after the last donation of whole blood. However, in certain circumstances wherein the donor has a rare blood type or is a giving for a particular family member because they have the same HLA type, then they can donate more than even earlier than 12 weeks. However, it's recommended that they should not exceed more than 6 blood donations a year. For donors who donate via platelet apheresis, so they can donate at a maximum of every 3 days. However, the recommendation is at least around 7 days for platelet apheresis. How about for those donors who have chronic conditions like hypertension or diabetes? Can they donate? Yes, they can. As long as the hypertension and the diabetes is controlled and the patient feels fine at the time of donation, then they can donate blood. They can donate even if they're taking antihypertensives and oral anti-diabetic drugs. Again, those certain antihypertensives might preclude them from donating. But again, as long as the hypertension, the diabetes is controlled, then they can donate blood. How about for those who are taking insulin? So for those who are on insulin, if the insulin is recombinant, then they can donate. However, for older insulins, which are from animal sources, they may have to be deferred. And that is because of the risk of Creutzfeldt-Jakob disease. How about for certain other conditions? There are certain conditions which may preclude the donor from ever donating blood, meaning a permanent deferral. So for those donors who have been diagnosed with HIV or AIDS, those who have been diagnosed previously with hepatitis B or hepatitis C, they are permanently deferred from donating blood. Those who have bleeding disorders or prolonged bleeding, and even those with heart disease, those who have heart failure, angina, and have undergone angioplasty, they will also be permanently deferred from donating blood, again for safety reasons, for the donor's sake. Certain conditions, for example, anemia, they may be allowed to donate blood if it was only from iron deficiency and once the anemia has been resolved. However, if the cause of the anemia is from an underlying hematologic disorder, then it is a reason for permanently deferring that donor. Patients who have been previously diagnosed with cancer, those who have active cancer or have had cancer before and undergone treatment, are permanently deferred from donating blood. However, recent data from the International Red Cross and Association for the Advancement of Blood and Biotherapies have stated that for those patients who are already in remission or those who have been considered cured of cancer, or those whose malignancies are not that aggressive, for example, basal cell carcinomas, which have already been treated, they can be allowed to donate. However, this is still not adapted in our local guidelines, and we would have to recheck or to think about allowing these particular patients to donate blood. For patients who have undergone cosmetic procedures, they may donate blood 12 months after their surgeries. Those who have had dengue can donate blood 1 month after recovering, as long as they have not received a blood transfusion during their illness. Those who have gout can donate blood as long as they're feeling well enough, they're feeling fine, then they can donate blood. Certain infections, certain sexually transmitted infections such as syphilis, gonorrhea, or genital warts would warrant an indefinite deferral. And when we say an indefinite deferral, they may be deferred for an indefinite amount of time. However, again, recent data from the International Red Cross and AABB have stated that as long as patients have already been treated for the syphilis, for the gonorrhea, and has been treated and has already recovered for at least 3 months, they may be allowed to donate blood. However, we still have, again, it's not yet adapted in our local guidelines, and you would have to check first, the feasibility of allowing such donors. Patients who have tuberculosis and are currently on treatment, they are deferred from donating blood temporarily. However, after being declared cured, they can donate blood after 24 months. Other conditions can warrant a permanent deferral, such as autoimmune conditions such as lupus, those who have psoriasis, those who have had schistosomiasis, and those with epilepsy, convulsions, and seizures are permanently deferred from donating blood. Those who are pregnant may temporarily be deferred from donating blood. However, 9 months after delivering or 3 months after weaning, they may be allowed to donate blood. Patients who have had those donors who have had minor allergies can donate blood at any time. However, those donors who have had anaphylaxis before are permanently deferred from donating blood. These donors who have other chronic conditions such as migraines or hyperthyroidism, they may be allowed to donate blood at any time as long as they're feeling fine. Patients who have had jaundice and proven to have had hepatitis A will be allowed to donate blood as long as it is already 6 months after their infection with a normal liver function test. In general, for patients who have had infections, for example, soft tissue abscesses, a dental abscess, mild pneumonias, they will be allowed to donate blood 4 weeks after recovering from their illness, and they are already off their antibiotics. What if these particular donors are taking medications? Will they be allowed to donate? Well, it depends. For donors who are taking aspirin, they will be allowed to donate 1 week after their last dose of aspirin. And for those who are taking clopidogrel, they may donate at whole blood at any time. However, the single donor platelets that we get from those donors who are taking clopidogrel will be marked as ineligible or unfit for a single donor platelet donation. Those who are taking antibiotics will be allowed to donate as long as first it's evaluated why the antibiotics being given in the first place, and it has already been 1 month after completing the treatment. These donors who are taking oral contraceptives may donate at any time. Also, those donors who are taking vitamins, who are taking herbal medicines, approved herbal medicines and supplements, as long as it's marked as a food supplement, they may donate at any time. Those who are taking beta blockers are a little bit of an exception because beta blockers can mask the symptoms of the hypovolemia that we are inducing when we donate blood. Thus, patients who are taking beta blockers are permanently deferred from donating blood. However, again, recent data from international studies have shown that those who are taking beta blockers do not actually fare worse when they are donating blood. And we have to rethink the wisdom of whether we should really defer patients who are donors who are taking beta blockers. Although not yet in our Philippine guidelines, but certain donors who are taking PrEPs or pre-exposure prophylaxis for HIV are allowed to donate 3 months from their last intake of PrEP. And it is because the PrEP or the pre-exposure prophylaxis for HIV tends to interact and might hinder HIV testing because it might yield a false negative result. What about for donors who have just recently received an injection? Well, it depends. For the donors who have received a killed vaccine or a toxoid such as Hib, influenza, tetanus, meningitis, pneumococcal, or HPV, they can donate at any time. For those donors who have received the hepatitis B vaccine, then they can donate 1 week after their dose of hepatitis B vaccine. This table shows the different timing of donation for different vaccines, especially live attenuated vaccines and other vaccines as well. In general, for those donors who have recently received live attenuated vaccines, they would have to wait for 1 month after the vaccination before they would be allowed to donate. Other vaccines such as cervical cancer, HPV, Japanese B encephalitis have varying amounts of timing durations before they can be allowed to donate. What if the donor has had surgery? Will they be allowed to donate? Well, yes, but if it's just a dental extraction, then they will be allowed to donate 72 hours after their procedure. However, for those who have undergone surgeries, especially if it's uncomplicated surgery, then they may be allowed to donate 12 months after having the surgery done. For donors who have received a transfusion previously or have received biologic products from human sources, then they may donate blood only 12 months after having received the product. What about for certain patient populations? For the population of males who have sex with males or MSMs, including those who engage in MSM with condom use, it warrants an indefinite deferral. For donors who engaged in prostitution and high risk sexual contact, donors who have taken prohibited drugs, especially IV drugs, those donors who have had multiple sexual partners, and those who engage in casual sex are also indefinitely deferred from donating blood. And again, when we say indefinite deferral, it does not mean permanent. It just means that they cannot donate blood for an indefinite certain amount of uncertain amount of time. However, again, recent studies from the Red Cross and also from the Association for the Advancement of Blood and Biotherapeutics have shown that that donors who engage in MSM and those who use condoms actually do not need to be deferred for quite some time. Initially, historically, they have been deferred for 12 months. However, newer data suggests that even if they were allowed to donate for as early as 3 months after their last contact, then it does not lead to harm, no, for the donor and also for the recipient. So, however, these particular nuances in international guidelines have not yet been adapted in our country. So it's something for our societies to still think about, you know, if we should be adapting these particular changes also. For those who have been imprisoned, donors who have been imprisoned, they can donate blood 12 months after their last incarceration. And it is because they have a higher risk of harboring transfusion transmissible infections. Those who have psychiatric disorders are permanently deferred from donating blood for ethical reasons. For those who have had recent alcohol intake, they will be allowed to donate blood 24 hours after their last alcohol intake. How about for those who have piercings and those who have tattoos? So these particular donors will be allowed to donate 12 months after their procedure. However, again, studies internationally have shown that deferring these particular doses, especially if the procedure has been done in a sterile manner, if the institutions who are doing the tattoos and the piercings are regulated, then it does not they do not have to be deferred for such a period of time. But again, since we do not have regulation in our country and we cannot really ensure the sterility and safety of having a piercing or a tattoo or a needle-induced tattoo done, then we still have to defer these patients for 12 months after their procedure. But it's something for us to think about. What if if the donor have recently traveled, will they be allowed to donate? So if the donor has stayed in a malaria endemic area for less than 6 months, then they can donate 6 months after leaving the malaria endemic area. If the donor resided previously in the malaria endemic area, then they can donate 12 months after leaving that area. For those donors who have had malaria before, they are able to donate 3 years after completing their treatment from the malaria. For those who have resided in the United Kingdom, in Ireland, in France, or in Europe for more than 6 months in the 1980s to 1990s, they are permanently deferred due to the risk of transmitting Creutzfeldt-Jakob disease because we cannot really test for CJD. So that's why we just defer the donors. Although, again, newer guidelines abroad would say that there's no wisdom currently to still be deferring individuals from Europe from donating blood, but we haven't adapted these guidelines yet. So, in summary, anyone can donate blood as long as they are healthy, as long as what they're doing, as long as their donation is voluntary. So the voluntary, non-remunerated donor is always the best donor. In selecting donors, we must ensure the safety of two individuals. First, the donor, and we have to make sure that they are of the right age, the right weight, they have good stable vital signs and stable comorbid conditions so that we do not induce harm on them. And also, we have to ensure the safety of the recipient. That's why we have to make sure that the donor is not harboring any transfusion transmissible infections and conditions which they may pass on to the recipient. And also, we have to ensure that the reason of donation is an altruistic one. So donors are not donating just because they want to be popular, just because they want to get money out of the donation. So the donation is always voluntary and non-remunerated. There's no reward for the donor. It's purely altruism. And the blood donation activity is also not an avenue for free testing because sometimes donors might just want to donate because they want to get tested for HIV. So this is not the avenue for that. And we have to remind our donors as well. And with this lecture, we hope that we have enjoyed your patients, and also everyone else to help us in saving a life by giving the gift of blood. Thank you.
Thank you, Dr. T, for emphasizing how finite a resource blood is and how we can encourage or how we can pick out donors, so that we can increase our donor pool. So for our next lecture, this is going to be about the rational use of blood components. I would like to introduce Dr. Camille Adrienne Tenchanco. She finished her Doctor of Medicine from the Pamantasan ng Lungsod ng Maynila and her internal medicine residency from De La Salle. And then she went on to do her fellowship in hematology at the UPPGH. At present, she is an active hematology consultant at the Asian Hospital and Medical Center at De La Salle University Medical Center, and she is currently an assistant professor too at the College of Medicine of De La Salle, and is presently the head of the Hospital Blood Transfusion Committee of the De La Salle University Medical Center. So let us all welcome Dr. Camille Tenchanco for her lecture.
Thank you very much for the kind introduction. I am Dr. Camille Ariadne C. Tenchanco, and I would like to thank the Philippine College of Physicians and our society, the Philippine College of Hematology and Transfusion Medicine, for the opportunity to present this lecture regarding the rational use of blood components. I have no actual or potential conflict of interest in relation to this presentation. The following are the objectives of this lecture. First is to understand the processing of blood components. Second is to discuss blood product modification and its clinical utility. And lastly, to present the indications for the use of each blood component. What are blood components? Blood component means a therapeutic constituent of human blood that can be prepared by various methods, which is intended for use in the treatment of patients. As seen in the photo, these are the potential of human blood. Whole blood is separated into components. First would be the red blood cells, which are used to increase the amount of RBCs after trauma or surgery or to treat severe anemia. Next would be fresh frozen plasma, which is used to correct deficiency in coagulation factors or to treat shock due to plasma loss from burns or massive bleeding. Third would be platelets, which are used to treat or prevent bleeding due to low platelet levels and to correct functional platelet problems. And lastly, cryoprecipitate, which is used to treat fibrinogen deficiencies. The DOH gave a Department Circular 2010-0013 last January 2010 regarding the operational guidelines for Blood Services Network in support to the implementation of the National Voluntary Blood Services Program for blood safety and adequacy, quality care, and patient safety. Dr. Rico T. has extensively discussed about donor screening procedures earlier. Let me just give a quick recap. The donor recruitment program shall target voluntary, non-remunerated blood donors who meet defined selection criteria. For donor screening, counseling, and collection of blood, donor screening shall include a medical interview, pre-donation counseling, and physical examination. Collection of blood may be conducted in the premises of the blood center or blood collection unit or during a mobile blood donation activity. All blood units for transfusion must test negative for the following: hepatitis B, syphilis, malaria, HIV 1 and 2, and hepatitis C. In addition, blood typing must be done on each unit, and when applicable, antibody screen should be done. Storage and transport of blood components shall be maintained at optimal condition to prevent or delay physical, chemical, or mechanical changes detrimental to blood components, and also to prevent or minimize microbial contamination and proliferation. The blood units should also be inspected appropriately. Any of the following, when present, will deem the component not acceptable: pink or red plasma as a result of hemolysis due to exposure to warm temperature during transport, presence of any blood clot, any sign of bacterial contamination such as discoloration or turbidity in the red cell plasma interface, or any sign of leakage in the bag. The possible causes of rejection and return of blood would be mislabeled blood sample, wrong component issued, improper storage during transport, and of course, blatant defects in the blood bag. For handling of blood components, maintaining a sterile, aseptic condition during all steps of handling blood components is very essential. Whole blood is collected from donors into a collection pack containing citrate phosphate dextrose anticoagulant in which multiple bags are connected, allowing blood and components to be transferred between bags aseptically using a closed system during manufacturing. The collection pack includes two different configurations. The Buffy coat collection set, also referred to as B1, is used in the production of red blood cells, plasma, and platelet components. The whole blood filtration set, also referred to as B2, is used in the production of red blood cells and plasma components, including cryoprecipitate. Platelet units are prepared from whole blood collected into a Buffy coat collection set with CPD anticoagulant. The whole blood donations are cooled to room temperature after collection. Blood components are then separated by centrifugation. The Buffy coat layer contains platelets and white blood cells. The Buffy coat layers from 4 donations of the same ABO blood group, along with plasma from one of the same 4 donations, are pulled together and processed in order to produce one pooled platelet unit or dose. Apheresis platelets are collected and prepared by an automated inline process using apheresis machines that separate and extract platelets from other cellular whole blood components by centrifugation. The rest of the blood components are returned back to the circulating blood of the donor. Plasma for transfusion is prepared by either centrifugation of whole blood or by apheresis. Multiple forms of plasma components are available based on differences in how the plasma is processed and stored following collection. Differences in the post-collection processing or storage of plasma or other plasma components cause variations in coagulation factor levels, fibrinolytic proteins, immunoglobulins, albumin, and other proteins. Frozen plasma contains all coagulation factors but has slightly reduced amounts of clotting factor 5 and 8. Apheresis FFP contains labile clotting factors 5 and 8 plus non-labile coagulation factors. Cryosupernatant plasma contains all coagulation factors but has reduced levels of the high molecular weight von Willebrand factor multimers and fibrinogen. Solvent detergent plasma, each unit contains 9 to 14 grams of human plasma proteins. And lastly, convalescent plasma, which is plasma collected from people who have recovered from an infection and that contains neutralizing antibodies against the causative pathogen. Plasma must demonstrate a pre-specified neutralizing antibody titer. Now, let us discuss blood product modification. The following blood product modification methods will be discussed as well as their clinical indications. Leukoreduction is a process by which the white blood cell content of cellular blood components is reduced. This may be accomplished in process during apheresis collection or by filtration of the blood product either in the manufacturer's laboratory or at the patient's bedside. Red blood cell units are passed through a filter that operates via two mechanisms: barrier filtration and cell adhesion. Barrier filtration partitions cell types based on size, whereas cellular adhesion between the filter medium and the leukocytes themselves also contribute to leukocyte retention. The figure shown here is a standard leukoreduction filter. The pink filter is used to filter red blood cells, and the white filter is used to filter platelets. The following are the indications for the use of leukoreduced components. First is to reduce the incidence of recurrent febrile non-hemolytic transfusion reactions. Second is to reduce HLA alloimmunization and HLA-mediated platelet refractoriness. And third is to prevent transfusion transmission of intracellular pathogens such as the cytomegalovirus and the human T lymphotropic virus types 1 and 2. Cytomegalovirus or CMV is an intracellular virus transmissible by cellular blood components that may have detrimental and even potentially lethal effects in immunocompromised patients. CMV reduced risk products decrease risk of transfusion-transmitted symptomatic CMV infection in recipients that are CMV naive and profoundly immunocompromised. At-risk patients would include pregnant women and their fetuses, low birth weight infants, hematopoietic progenitor cell transplant recipients, solid organ transplant recipients, severely immunosuppressed patients, those with congenital immunodeficiency, and HIV-infected patients. Blood products that are considered to have reduced risk include the following: CMV seronegative cellular blood components from individuals who test negative by an FDA-approved screening test for CMV antibodies, and leukoreduced cellular blood components. Inactivation of donor lymphocytes by gamma or X irradiation can prevent the proliferation of transfused lymphocytes and the development of transfusion-associated graft-versus-host disease. If a patient requires irradiated products, all cellular products, for instance, red blood cells, whole blood, apheresis granulocytes, whole blood-derived platelets, apheresis platelets, and liquid plasma should be irradiated. Cellular products that may have a close HLA match to the recipient should also be irradiated. Irradiated blood products are indicated in Patients with congenital immune deficiencies, those with Hodgkin's disease or receiving T-cell suppression therapy including purine nucleoside analogs and antagonists, recipients of stem cell or bone marrow transplants, patients with aplastic anemia receiving immunosuppressive therapy, recipients of directed donations from family members, and recipients of HLA-compatible single-donor platelets and granulocyte transfusions. Using an automated device, a cellular blood product is repeatedly washed with normal saline solution. In this manner, there is greater than 95% reduction of plasma in its constituents. Basically, during washing, the majority of plasma proteins, antibodies, and electrolytes are removed. Indications for washed cellular components would include anaphylactic and recurrent significant allergic transfusion reactions that are unresponsive to pre-medication, for recipients with IgA deficiency, particularly those with a prior anaphylactic reaction, avoidance of hyperkalemia in patients predisposed to arrhythmia from rapid transfusion and/or large volumes, neonatal alloimmune thrombocytopenia, and recurrent febrile non-hemolytic transfusion reactions in patients unresponsive to leukocyte-reduced products and antipyretic pretreatment. Volume reduction involves centrifugation of cellular products followed by aseptic removal of the supernatant which contains excess plasma and storage medium. In addition to decreasing volume, this process reduces the total amount of plasma proteins including antibodies. Some loss of platelet function through platelet activation may be anticipated, but preservation of cellular functionality is maintained. It should be noted that volume reduction is not a substitute for washing or for dosing with small alicos. Cellular components with reduced plasma volume may be used when the volume status of a patient is being aggressively managed, such as a fetus undergoing in utero transfusion, infants with compromised cardiac function, or adults who may tolerate volume poorly. This approach may also be used to prevent or limit hemolysis when platelets with EBO-incompatible plasma are transfused. If a sterile docking device or sterile entry into a single unit of thawed plasma in cryoprecipitate, RBCs or platelets is available, it may be possible to split units into alicos, making it easier to provide smaller dosing. In addition, a single blood unit may be transfused over several days and therefore decrease donor exposure. Indications would be for patients who may benefit from smaller doses without increasing risk due to exposure to additional donors. Pathogen inactivation methods prevent the replication and growth of a wide variety of viruses, bacteria, and parasites by damaging genetic material or disrupting cellular membranes. When referring to the method to treat blood components for pathogens, the term pathogen inactivation is used. Pathogen reduction, however, is the intended effect of this modification to decrease the counts of microorganisms. The Food and Drug Administration has approved pathogen inactivation technologies that can be employed as an additional safety measure to help maintain a safe blood supply. The FDA has approved the following pathogen inactivation technologies, namely the Intercept Blood System and Octaplas. For its clinical utility, it is approved for the use in patients with acquired coagulation factor deficiencies, cardiac surgery, and thrombotic thrombocytopenic purpura. Glycerol is added to red cells as a cryoprotective agent. The red cells are then frozen at or below negative 65 degrees centigrade. Frozen red cells may be stored up to 10 years or sometimes longer if there is a particular need for specific units. According to the Australian Red Cross, frozen red cells may be used for patients with rare red cell phenotypes or who have multiple red cell antibodies or for autologous collections where liquid preserved blood cannot meet the patient's demands. The Joint Trauma System Clinical Practice Guidelines Training Series gave the recommendations regarding the use of frozen and deglycerolized RBCs. The primary indication for the use of DRBCs is to supplement liquid RBCs during surge periods of increased transfusion requirements. DRBCs may be useful in lieu of liquid stored RBCs for all RBC transfusion requirements, including massive transfusions. Now, we will be discussing the indications for the use of each blood component. Red blood cells, or RBCs, consist of erythrocytes concentrated from a whole blood donation or collected by apheresis. They contain citrate anticoagulant and usually one of several types of preservative solutions. Depending on the preservative anticoagulant system, the hematocrit of RBCs is about 55 to 65% for additive solutions and about 65 to 80% for citrate phosphate dextrose adenine solutions. RBCs contain 20 to 100 ml of donor plasma, but usually less than 50%, in addition to preservative and anticoagulant. The typical volume of RBCs, including additive solution, is approximately 300 to 400 ml. Each unit contains approximately 50 to 80 grams of hemoglobin, or 160 to 275 ml of red cells, depending on the hemoglobin level of the donor, the starting whole blood collection volume, and the collection and processing methods used. The use of fresh whole blood and whole blood should be discouraged, and patients should be given specific blood products as indicated. However, the following may be considered as indications for fresh whole blood or whole blood transfusion: evident massive blood loss and coagulopathy, when specific blood products are not available or when blood products are not enough to resuscitate the patient, such as in cases of trauma casualties who will be requiring massive transfusion and patients with hemorrhagic shock. Dosing should be based on the patient's clinical condition, estimated blood loss, and other measures being used to maintain hemodynamic stability. Studies supporting this approach include military trauma, where they are able to transfuse very fresh, or defined as less than 24 hours old, whole blood, which is not currently routinely available in civilian institutions. There is a general agreement that RBC transfusion is typically not indicated for hemoglobin levels greater than 10 grams per deciliter, and that transfusion of RBCs should be considered when hemoglobin is less than 7 to 8 grams per deciliter, depending on patient characteristics. The decision to transfuse red blood cells should be based on a clinical assessment of the patient that weighs the risk associated with transfusion against the anticipated benefit. As more studies addressing RBC transfusion becomes available, it becomes increasingly clear that liberal transfusion strategies are not necessarily associated with superior outcomes and may expose patients to unnecessary risks. This table shows selected multi-center randomized controlled trials informing RBC guidelines. These recent RCTs have consistently demonstrated the safety of using a restrictive threshold of 7 to 8 grams per deciliter for most patients. As part of creating the 2016 AABB transfusion guidelines, a review and meta-analysis of 31 randomized controlled trials involving a total of 12,587 subjects in various clinical settings, ranging from acute coronary syndrome to hematologic malignancies to orthopedic surgery, etc., concluded that restrictive thresholds of 7 to 8 grams per deciliter when compared to 9 to 10 grams per deciliter were not associated with higher rates of adverse clinical outcomes such as 30-day mortality, cardiac morbidity, and infection, with the exception of two small trials in subjects with acute myocardial infarction. Furthermore, the lower transfusion threshold decreased the likelihood of receiving POC-RBC exposure by 43% overall, and some studies showed survival was higher in certain patients who were transfused less, such as those with acute upper GI bleeding. However, caution is warranted before extrapolating this research on restrictive transfusion strategies to other patient groups that have yet to be studied, or where the data are extremely limited. In our practice, a large proportion of all cancer patients experience anemia associated with the disease itself, or the treatment regimen, or both. The severity and duration of cancer-related anemia may vary with each malignancy's unique capability to suppress hematopoiesis and with the specific chemotherapy used. This makes it difficult to develop a single set of RBC transfusion guidelines to cover all oncology patients. This challenge is further compounded by the lack of clinical trials in the red cell literature looking at this particular patient population. A recent meta-analysis identified 31 papers looking at restrictive versus liberal transfusion thresholds, but only 2 of those dealt with oncology patients, and in both articles, only subjects with hematologic malignancies were analyzed. A 2017 Cochrane database review identified 4 more studies, one of which was not randomized. Altogether, this Cochrane Library publication found just 240 subjects for their analysis and thus were unable to draw any conclusions about the superiority of a restrictive transfusion strategy or policy. Likewise, the AABB did not make a recommendation for a transfusion threshold in oncology patients, nor did the National Cancer Network, which urged physicians to use their clinical judgment based on the patient's symptoms, cancer course, treatment response, and comorbidities. The following are the indications for platelet transfusions. It is used to treat bleeding due to critically decreased circulating platelet counts or functionally abnormal platelets. It is used prophylactically to prevent bleeding at pre-specified low platelet counts. In general, we maintain a platelet count at greater than 10,000 in stable non-bleeding patients, at greater than 20,000 in unstable non-bleeding patients, and at greater than 50,000 in patients who are actively bleeding or undergoing major invasive procedures or surgery. In the absence of coagulopathy or thrombocytopathy, the American Association of Blood Banks or the AABB clinical practice guidelines suggest prophylactic platelet transfusion for patients having major elective non-urachal surgery with a platelet count of less than 50,000. Procedures including paracentesis, thoracentesis, liver biopsy, sinus aspiration, and dental extraction may also require platelet transfusion. Prophylactic platelet transfusion for patients having an elective central venous catheter placement with a platelet count less than 20,000. Prophylactic platelet transfusion for patients having elective diagnostic lumbar puncture with a platelet count of less than 50,000. A threshold of 80,000 has been proposed for spinal and epidural anesthesia. Urologic or ophthalmologic procedures may require a higher platelet count near 100,000. Fiber optic bronchoscopy or GI endoscopy without biopsy may be safely performed by experienced operators in the presence of a platelet count of less than 20,000. Bone marrow aspiration biopsy may be safely performed with counts at or below 10 to 20,000. Patients with congenital or acquired defects in platelet function may be transfused for critical bleeding or before major surgery regardless of platelet count. Transfusion is generally not indicated when platelet dysfunction is extrinsic to the platelet, for instance, uremia, wherein the underlying condition should be managed when at all possible to avoid platelet transfusion. When platelet surface glycoproteins are absent, such as in Glanzmann thrombasthenia or Bernard-Soulier syndrome, transfusion should be undertaken only when more conservative efforts to manage bleeding have failed, since alloimmunization due to repeated transfusion may also cause future life-threatening refractoriness. P2Y12 receptor inhibitors and direct glycoprotein 2B3A inhibitors impair platelet function. Platelets should not be transfused prophylactically in the absence of thrombocytopenia, but high-dose therapeutic transfusion may be required for life-threatening hemorrhage in patients on these medications. Now, for disseminated intravascular coagulation or DIC, transfusion is appropriate in children and adults with platelet counts less than 50,000 who have active bleeding, require an invasive procedure, or are otherwise at high risk for bleeding complications. The platelet count may fall below 50,000 when greater than 1.5 to 2 blood volumes have been replaced with red cells or other components. A transfusion target of greater than or equal to 50,000 is recommended for acutely bleeding patients and greater than 100,000 for those with multiple trauma or CNS injury. In the presence of microvascular bleeding, transfusion may be appropriate when counts are known or suspected to be less than 100,000. Early aggressive platelet therapy has been associated with improved survival in several retrospective studies. Platelets should be transfused prophylactically to patients with platelet counts less than or equal to 10,000 to reduce the risk of spontaneous bleeding in hospitalized adult patients with therapy-induced hyperproliferative thrombocytopenia. The AABB guidelines emphasize transfusing a single apheresis unit or its equivalent. Prophylactic platelets may be given despite a higher platelet count if clinical factors such as drug-induced platelet dysfunction, fever and/or sepsis, hyperleukocytosis, tumors with greater risk of hemorrhage, use of anti-thymocyte globulin, acute graft versus host disease, or hepatic veno-occlusive disease are present. Indications for plasma transfusion would include the following: active bleeding or risk of bleeding due to deficiency of multiple coagulation factors, urgent reversal of warfarin when 4-factor prothrombin complex concentrate is not available and cannot wait for vitamin K to take effect, and massive transfusion with coagulopathic bleeding. Other indications would include bleeding or prophylaxis of bleeding for a known single coagulation factor deficiency for which no concentrate is available, plasma exchange for thrombotic thrombocytopenic purpura or TTP. For a review, TTP is a medical emergency requiring immediate plasma exchange. If plasma exchange is not immediately available, consider plasma transfusion as an emergency secondary treatment until plasma exchange becomes available. And plasma is also indicated for rare specific plasma protein deficiencies for which no concentrate is available. Plasma dose is determined by patient's weight and clinical condition. Plasma should be administered in doses calculated to achieve plasma factor concentrations of at least 30%, which is the minimum hemostatic level for most coagulation factors. This is usually achieved with the administration of 10 to 20 ml per kilogram patient weight, though more may be required depending on the clinical situation. For liver disease, plasma may be used to replace multiple coagulation factor deficiencies due to liver disease in patients who are actively bleeding or prior to an invasive procedure that would create a risk for bleeding. However, the response may be unpredictable, and complete normalization of hemostatic defect may not occur. Post-transfusion coagulation testing may be necessary to evaluate efficacy. Patients with liver disease may safely undergo operative or invasive procedures when the prothrombin time is less than or equal to 1.5 times the mid-range of normal. Patients on warfarin who experience serious bleeding are treated with INR-based doses of vitamin K and plasma or prothrombin complex concentrates as clinically warranted. Recent guidelines suggest that 4-factor prothrombin complex concentrates are preferable to plasma transfusion for situations requiring urgent reversal of warfarin. However, when prothrombin complex concentrates are not immediately available, plasma transfusion may be necessary. As in liver disease, patients on warfarin may safely undergo operative or invasive procedures when the prothrombin time is less than or equal to 1.5 times the mid-range of normal. Plasma may be used to treat excessive microvascular bleeding as determined on joint visual assessment of the operative field by the anesthesiologist and surgeon when the coagulation screening test results are abnormal and are not available in a timely fashion. For massive transfusion, recent trends based on retrospective studies advocate using a high plasma to RBC ratio to improve survival. However, further studies including randomized controlled trials are necessary to determine the risks or benefits of a high ratio strategy compared to a laboratory-driven approach. The following are contraindications to the use of plasma products. It is not recommended to be used in order to increase blood volume only or to increase albumin levels or for nutrition. Second, a coagulopathy that can be corrected by adjusting warfarin dose and/or administration of vitamin K. And lastly, normalizing abnormal coagulation screen results in the absence of bleeding. In summary, we have discussed processing of blood components, blood product modification and its clinical utility, and indications for the use of each blood component. The following are my references to this presentation. Again, thank you very much for listening. I hope you learned a lot. Have a great day, everyone.
Thank you so much, Dr. Tenchanko, for that wonderful discourse. So we've followed the blood product from the donation and its journey into the laboratory as it is prepared for transfusion. And we looked also at the side of how we physicians or clinicians should decide on which patients we should be able to give these blood products that are very, very scarce. No? So, and now we look into, as we go to the third lecture, we would like to look into the hospital structure or the committee that oversees all of these things. So we'd like now to call on our third lecturer, Dr. Rosalind Valerie Pua Cortez Villanueva, who will be lecturing on the Hospital Blood Transfusion Committee. Dr. Villanueva finished her Doctor of Medicine at the UER MMMC and had her internal medicine residency at the Hospital ng Maynila. She then went on to fellowship in hematology at the UPPGH. At present, she is the chairman of the Department of Internal Medicine at HealthServe Los Baños Medical Center. She is also the head of the Blood Transfusion Committee of the said hospital, as well as the Laguna Doctors Hospital and the Rizal Medical Center. She is an active consultant at HealthServe Los Baños Medical Center, Laguna Family Hospital, Laguna Doctors Hospital, and she is a medical specialist too, part-time at the Rizal Medical Center. So ladies and gentlemen, let us all welcome Dr. Villanueva for her lecture.
Hello, good afternoon. Kamusta na po kayo? I hope that you are all excited to learn how we can empower our Hospital Blood Transfusion Committee, which is the topic that was assigned to me for today. So I am Dr. Rosalind Valerie Cortez Villanueva, and let's start. For this afternoon's talk, I have prepared these objectives to help us learn more about the BTC. So we are going to highlight its importance, its roles and function, describe the structure and composition, enumerate topics and agenda during the meetings, and cite the challenges to a fully functional HBTC and provide strategies in overcoming these difficulties and how to have an engaging transfusion committee meeting. First and foremost, we have to know the importance of our Hospital Blood Transfusion Committee. So the HBTC, or the Hospital Transfusion Committee, the Blood Management Committee, the Blood Utilization Committee, Blood Users Group, or as called by many other names, would actually smell as sweet. So if you didn't know yet, all institutions are required by law to have an HBTC. As mentioned in the DOH Administrative Order number 2005-002 under the Republic Act 7719, which is known as the National Blood Services Act. A functional HBTC is a prerequisite for licensing and authorization of a blood service facility by the DOH and accreditation by the Philippine Health Insurance Corporation, also known as PhilHealth. So before I proceed, I just want to ask you, if you're Is your HBTC in your institution active? Or is it merely a dummy committee for completion of requirements for PhilHealth? So in case you don't know or you are not familiar with your HBTC and its rules, don't worry, hindi ka nag-iisa. Even in international settings, the role of HBTCs are varied and not standard. And in an international survey analysis, it was found that there really are differences in the reported variables for each HBTC around the world. The HBTC plays a crucial role in the implementation of national guidelines on the clinical use of blood at the regional, local, and hospital level. And it should have the authority within the hospital structure to determine hospital policy in relation to transfusion and to resolve any problems that may be identified. As such, there is really a need to ensure firstly that your HBTC is set up and secondly that it functions efficaciously and efficiently. And with that, these are the roles and functions of our HBTC according to the WHO. So one, it should monitor the safety and adequacy and reliability of supply of blood, blood products, and other alternatives to transfusion. Two, it should develop systems and procedures for the implementation of the national guidelines on the clinical use of blood, including development of hospital blood ordering schedules such as your MS-BOSS or your massive transfusion protocol. Number three, promoting the effective implementation of the national guidelines through continuous education and training of all clinical and blood bank staff involved in the transfusion process. Four, this one we do this all the time, monitoring the usage of blood and blood products in the hospital. Five, we should monitor also once after we promote the national guidelines, we should be able to monitor the implementation of these guidelines and take appropriate action to overcome any factors that may hinder their effectiveness. And lastly, review incidents of adverse effects or errors associated with transfusion and identify any errors and give corrective action if required and refer them to the National Committee and the Clinical Use of Blood. So I think number 2 and number 6 are the ones that we practice most of the time during our HBTC meetings. Now that you know the roles and functions of your HBTC, it is now time to form our team. So this committee should be multidisciplinary, including departments involved in providing and prescribing our blood products. So we have representatives from our cutting departments such as OB and surgery, and then we have anesthesiology, internal medicine, and of course our nursing department and laboratory services. The team should also include members who are external to the hospital setting. Most importantly, I think the executive management. Because during meetings, you would be discussing about policies and recommendations, and it would be most useful that someone from the admin is already present and can approve of your suggestions right then and there. And since the blood transfusion process falls under the quality assurance management, a representative from them would also be most welcome. A patient or a consumer representative can also be included since they are, of course, the primary recipients of your blood products. Other members that can be useful would include your IT, if ever you want to upgrade to electronic forms, finance, for requests for additional items such as filters and equipment, also your pharmacists and bioethicists if available. Now, if your hospital is lucky enough to have a hematologist, then ideally they should also be part of the committee alongside the wish list of having a blood bank manager, a transfusion practitioner, and a representative from the department involved in the education and training of your staff. Even though there are many members of our team, there are still special roles in the HBTC. So firstly, the chairperson. So ideally, this should be a healthcare professional other than your hematologist and blood bank head, who is also regularly involved in blood transfusion. This is to engage the other specialties to participate in your committee. So the chairman has many roles such as scheduling meetings, ensuring that the committee meets regularly, setting agendas to fulfill its objective, encouraging members to participate in discussions and provide their opinions, ensuring members are provided with data and tools that would enable them to develop recommendation, arrange for the minutes of the meeting to be distributed, and ensure that action items are reviewed and completed, lies between the hospital medical advisory for recommendations for improvement and immediate action, maintain awareness of members about the ethical aspects of their decision making, and provide an opportunity for all members to declare a conflict of interest at any time. Ang daming trabaho ng chairman talaga. So that's why we have the second role, which is the secretarial or administrative support. So he or she records attendance at all meetings and would distribute the minutes of the meeting and also ensure that action items, decisions, and recommendations are well documented in those minutes. So she or he will also distribute documents, background documents for discussion for the committee members, I mean, and can also assist the chairperson in scheduling the meetings. So the third role is that of our wish list, the transfusion safety or transfusion practitioner. Ano ba yun? Ano ba talaga yun? So this is a healthcare professional with either a nursing or laboratory background whose main focus is to improve patient safety relating to blood transfusion. This can also be performed by your nursing or laboratory personnel, but having someone dedicated to this role is often more effective. So the task of the transfusion practitioner is to develop policies and procedures for patient identification and blood administration, reviewing of your blood utilization, following up and reporting adverse events and reactions related to blood transfusion, and also developing and delivering educational programs, performing audits and presenting this data to the committee for review and discussion, to develop recommendation and improve performance and prevent errors and incidents. The last role is a special role for our hematologist as the transfusion lead. So I will not go into details regarding this role, but basically, the transfusion lead should provide the medical leadership of clinical and laboratory aspects of transfusion, complying with the current regulatory frameworks and guidelines. And now, finally, we get to the nitty-gritty of our committee. So what are the agenda that needs to be discussed during the meetings? When I was first starting out with the HBT of our institution, we only reviewed about transfusion reactions and wastage of blood products. But now I know that the HBTC holds so much more. So there are many things to discuss. So such as, of course, as mentioned, the blood utilization and wastage, two, development and approval of guidelines for ordering of blood for transfusion. You know, in a tertiary hospital where I am affiliated, that has been around for at least, I think, more than 80 years, we just recently made the blood transfusion manual, considering that this is such an old hospital and fully functioning at that. With that manual, we also included the maximum surgical ordering scheduled, or the MS-BOSS, which is actually a guide on the number of units needed by each surgical procedure. So this was done in collaboration and approval of the different departments such as surgery, OB, ENT, and anesthesiology to ensure that they would follow the recommended units and avoid excessive requests for blood. An example prior to our MS boss was an OB. The OB department requested for 6 units of PAC RBC for a cesarean section in a patient who only had mild anemia. So the MS boss would now serve as the guide for both the requesting department and the blood bank on approval of blood requests. Other agenda would include also the quality improvement initiatives related to transfusion. For example, ensuring that the blood transfusion of PAC RBC does not exceed 4 hours to avoid bacterial contamination. Even the transport of blood products within and outside the hospital can be discussed, as proper coolers or collection trays should be used. The HBTC should also have the authority to make policies to improve the use and provision of blood for BT, including your informed consent. The informed consent in another hospital where I am affiliated used to use the general consent form for surgical procedures, but this did not include the adverse reaction that might happen during BT and might lead to confusion and lack of knowledge of both the patient and relative. And thus, we also made and revised our own informed consent specifically for blood transfusion. The next agenda would be your audit on blood utilization and administration per department, as this may also give an insight on which department uses the most number of bloods. Of course, adverse reactions, incidents, errors, and near misses should also be discussed. So we had an incident before wherein the patient was about to receive a blood unit that was not actually his. And the good thing is that the nurse on duty was able to detect that the name on the blood unit was not the same as the patient, although the blood unit had the same blood type as the patient. So this is what we call as a near-miss event. Introduction of newer products such as your leukodepleted PAC RBC, apheresis platelets should be introduced to your team so that they will also become familiar with them and use them properly. I often get calls from nurses on duty asking when the only available blood product is, for example, leukodepleted, and they would ask, is this acceptable? So meaning that they have never encountered this before, and thus the need to ask. When actually leukodepleted blood products are better to use to avoid blood transfusion reactions. Also, in line with that, the dissemination of transfusion information and education for staff training and competency is very important. So this is also a job for the HBTC, ensuring that a continuous education regarding blood transfusion is given. Another type of a transfusion protocol is what we call the massive transfusion protocol. So in our institution, the one with the newly made manual for our tertiary hospital, we now included also the MTP or the massive transfusion protocol as a guide for both the cutting departments and the blood bank in the release of blood units once the MTP is activated. So for example, a patient with a gunshot wound came into the ER, then the surgery department can easily activate the MTP protocol so that the laboratory may continue to release blood products until the patient is stable and the activation of the MTP is ordered to stop. At the start of the COVID-19 pandemic, we also saw a short period of blood shortages as the donors during that time trickled. So it is also important and should be part of the things that the HBTC should discuss and plan, the contingency or emergency planning for potential blood shortages. Because we think it may never happen, but when actually it already has. With that, here are some policies that the HBTC should consider in making. So again, the informed consent should be specific for BT and not use the general form for operations. the indications for blood products and ordering practices, including your MS boss. Patient identification for collection and administration is also crucial, as human error is the most common cause of major transfusion reactions such as hemolysis. So in my institution, we also included the checking of the blood process, in which two nurses or nurse aides and one doctor should not only double but triple check the blood unit intended for the patient prior to its administration. Since there is a disparity and misconception about practices and guidelines, it is also now the time to make a consensus and correct the old habits. For example, transfusing your blood products for a maximum of 4 hours only, not 6 hours. The mandatory giving of pre-medications is actually not recommended for those with no history of BT or transfusion reaction. And one of the most common errors is the ordering of the 6 hours post BT CBC, when in fact we can already request for a repeat CBC even after 15 minutes from the transfusion. So there are many misconceptions and hand-me-down practices that we can correct and teach our colleagues. And as I mentioned earlier, a massive transfusion protocol can be made for your institution for faster activation if needed. Other policies for reporting of not only errors and complaints, but also corrective and preventive measures should be uniform and easy. So this is, I think, the perfect time for your IT to help out. So they can make electronic forms that are simple and easy to use and easy for collation of data for analysis. Policies on management and performance audit should also be in place. An easy tracing for transfusion-transmitted infections can be entailed if there is a proper policy in place. The introduction of new blood products alongside with staff training to maintain competency of the staff and in all related blood transfusion procedures. And lastly, a policy on blood shortage management, and this actually can be the perfect avenue for you to introduce the concept of the patient blood management. So the PBM with its 3 pillars, namely 1, detection and management of anemia and IDA, 2, minimization of blood loss and optimization of coagulation, and 3, leveraging and optimizing the patient-specific physiological tolerance of anemia. So PBM is a concept that we will be gearing towards in the near future. Okay, so we now know who our members are, what do we do, and what do we discuss. So our challenge is to maintain our HBTC. So in practice, there are only a few fully functioning transfusion committees that actually exist due to the numerous challenges that it continuously faces. The endorsement of the committee and your activities by the hospital board is actually very crucial for your success. So some of the challenges that we encounter, number 1, the attendance. So this is an adequate and a consistent attendance is really a struggle that most HBTC experience. This may be due to the fact that 1, it is only very voluntary and non-remunerated. So your representative may already have commitments like to the clinics and other societies, and thus the timing of your meeting is a factor. So number 2, the lack of central guidance. So the chair of your committee may not actually be a transfusion expert and will rely only on the transfusion team to provide context and expert information. Monitoring of your performance and improvement can also be a problem. For example, in my tertiary hospital, in 1 quarter, only 2 blood transfusion reactions were reported out of the hundreds of blood units released. Imagine that. But most likely, these forms were not submitted, hence the low census. And if these events are not being reported, then we might miss the chance of improving our services. Maintaining an active and competent HTC is also a problem. There should be ongoing professional education of healthcare professionals. And due to the high staff turnover rate, nowadays, nurses and medtechs are going abroad so fast that you have just finished training them, and the next month they're already gone. So this means there is really a lack of investment time. Okay, so we present some strategies to overcome our challenges. So our first challenges is increasing attendance. So suggestions are, of course, you have to get the support of your senior management. Make it a required thing to attend. So have an appropriate venue, appeal to your different departments or section heads that they should assign a regular representative not only for the meetings but for the committee as well. And during the meeting, highlight the members that attend, regularly review attendance, and request for new members if there are repeated absences. The Hospital Transfusion Committee may also consult and collaborate with different departments regarding the audits. So ask for topics that each member would like to be discussed. So make their attendance count. Now, the second challenge is how to encourage the other specialties to actively participate. So, set an ideal time. Make sure that your meeting is not too late or not overly extended. Set your agenda and you should stick to it. You may also introduce an element of education. For example, presenting a difficult cross-matching case and discuss it during the meeting. So, it will also be a learning process. And to keep other departments on their feet, you can use their audit data records to instill a friendly competition among them. Make the topics of the meeting relevant to the different areas. Do not focus mainly on blood transfusion and reactions. Also ask the concerns of the lab, the admitting section, the finance, to make it purposeful for everybody. Make decisions regarding transfusion policies even in the absence of their representative. For example, if you want to implement your MS BOSS, but the surgery and OB department is not present, so you should still instill and authorize the use of your MS BOSS to remind the authority of your committee to make decisions even in their absence, and thus would encourage them to attend your meetings. Always ask your members for their opinions and structures and the topics they want to discuss. Review how your meetings are conducted, the frequency, the decision making, and provide or suggest alternatives that would benefit the group. The third challenge is monitoring key performances. So, first of all, I think you have to make user-friendly formats kasi this is an added job for our nurses and our medtechs and our laboratory. So, if the reason for a low reporting is due to a tedious process of forms, then maybe we can make it simpler and a quicker format. So, you have to document every meeting and make an annual report and submit to the executive committee or the executive board to show the effectiveness of your transfusion committee. And since again, this is all voluntary and we are not getting paid for it, acknowledgement is very important. You should celebrate every success and its corresponding members. Publicize at every opportunity as this will serve as the motivation for your committee members. Bragging rights na lang. Do not limit your hospital within yourself. You can collaborate with other facilities or institutions such as Red Cross, sharing ideas on what works and what does not for the betterment of all. And finally, the fourth challenge is to provide resources and education to support your members in the requirements of their role. So before we decide in providing resources for our members, I think the most important thing is to find a member who would be willing to do the work and participate actively in your committee. So you should really hunt for a willing and productive member. So with every networking activity, if there's a meeting or if it's a gathering, headhunt potential members and recruit them personally using a one-to-one approach. Emphasize the mutual benefits that may arise from being a part of your committee, and make sure that the members are aware of their roles and that you can further outline their commitment to the group. You can invite also your finance department to give an insight on the financial perspective of transfusion, and at the same time ask for assistance, financial assistance for CME activities. So for example, registration to annual conventions of your PBCC or your PCHTM or your PSHBT. And with that, we end our discussion on HBTC. So just to review, the role of your blood transfusion committee can be described as the promotion of the best transfusion practices through the enhancement of awareness and education, facilitation of your policy development, monitoring and review of your blood and blood products, and adverse events using these products. So if it is properly constituted and adequately resourced, the HBTC can be a powerful force for improving your transfusion safety. I hope that with our discussion, you are now excited and willing to join our hospital blood transfusion committee. So thank you for listening and good night.
Thank you so much, Dr. Villanueva, for that wonderful lecture and insightful lecture about the hospital blood transfusion committee, which is actually a very, very important committee each hospital should have. Pero usually it's not that very highlighted, maybe, no? So hopefully that is the reason why we want to encourage webinars like this, no, to highlight this important committee. So we'd like to call on, Dr. Salamanca and I would like to call on our three lecturers for the Q&A.
Dr. Marge, they really delivered very helpful lectures for all of us. The lectures are very helpful in our hospitals, no, in our practice. So simula pa lang, I would like to thank our lecturers talaga. I didn't even notice the time, no? Kasi they really gave beautiful, informative lectures. So, let's start the ball rolling na. May mga questions na po eh.
Maraming questions actually for our first lecturer.
For Dr. Rico, yes po.
Okay, Dr. go on.
All right. Si Dr. Rico, actually, kayo po yung maraming question. So the first, Doctor, what's the reason for the 24 months deferral for TB patients?
Okay. Actually, we also tried to search the literature as to why, as to the exact reason why we have to defer patients who have been treated with for tuberculosis for 24 months. However, sadly, even with this recommendation has been derived from WHO standards. However, you are really uncertain as to why the deferral for 24 months. We would surmise that it comes from the to ensure that there is no infectivity that's going on with patients who have been treated with tuberculosis. Although honestly, there's not much that has been said with regards to this duration. And in addition, certain other policies in other countries have done away with having the 24-month deferral for TB patients, TB treated patients.
Mm-hmm. All right. So there's no specific talaga na reason why. Okay, maybe it because of the because of the medications that our donors are taking also.
Yes, that would be one. However, we expect that for a certain amount of time that these medications would have already been washed out.
Yeah.
So yes, and well, the interesting thing is other countries have done away with having the 24-month deferral. It's something that we could look into no, so
Okay.
that we can increase our donor pool.
Okay. So
That's
next
correct.
question. Mhm.
So now we look into, there are several questions about COVID-19 and how COVID-19 affects donors or the donation. So one question is, can a donor donate blood if he was a close contact of a COVID-19 positive patient, but the donor himself is asymptomatic and is negative for COVID-19 antigen test? And maybe you can already answer the other questions, that what if it's a COVID recovered patient, and what about if they just recently got a vaccine for COVID? So that's
Okay.
for 3 individuals.
Okay. So first, if the potential donor has been a recent contact of someone who has had COVID, as long as the donor is feeling fine, and on top of that has already tested negative with the rapid with the antigen test, then the donor may proceed with the donation. What if you had COVID? As long as you have already recovered from the COVID, as long as you are already feeling fine from the COVID, you've already finished your quarantine, you're already feeling fine, well enough to proceed with the donation, then you may proceed with you may proceed with the donation. However, if the prospective donor has had severe COVID, so the recovery is a bit longer, and on top of that, if you have received blood products, remember, if the donor has received blood products, they have to be deferred for 1 year. No? So those are the things that additional things that we'd have to think about. Now, how about if you have received a vaccine recently? So as long as the donor feels well enough after having received the vaccine, then there is no set deferral time for them. However, by experience, we know that after receiving the vaccine, we really don't feel that well enough to go out to do our activities. So as long as the donor is feeling well enough to pursue the donation, then they will be allowed to donate. Of course, barring the other requirements as well.
Thank you, Rico.
Okay, Dr. Rico, from COVID, you also mentioned about dengue. So I noted in your slide, if the patient recovered from dengue 1 month after recovery without transfusion, he can donate. How
Yes.
about if the patient had transfusion, like platelet
Okay.
transfusion? How long po?
So for someone who has had a transfusion, then they would have to be deferred for 12 months, no, or 1 year before they will be allowed to donate. And again, as long as they're feeling well.
Okay. Thank you. So for the next question here in our chat box from Dr. Ordonia, in your opinion, can we now adapt the new international deferral guidelines here in the Philippines?
Okay, that's a very good point, doctor. No, because these honestly, these guidelines that we have currently have been formulated since 2011, and a lot of things have already happened since 2011. A lot of research has already gone into deferrals, like for example, for MSM, for the LGBT community. A lot of studies have already shown that they do not increase the risk of giving blood products which may be harmful for recipients. So it really is high time to review our policies with regards to accepting donors. So again, with the objective of increasing the blood pool and increasing the safe blood pool that we have.
Yes, I totally agree that we need to rehash or rethink some of our guidelines. Yeah, we have to move on with the times, no? So
Agree.
let's give Rico some breathing space, and let's move on to Dr. Camille. We'll go back to you, Rico, in a while, no? So let's focus our attention to Dr. Camille first. And so the question is, do we routinely need to give paracetamol or diphenhydramine prior to blood transfusions for, like, let's say, PAC RBCs or platelets?
Actually, that's a very common question. The use of pre-medications. Basically, if you will review all the randomized control trials and the systematic reviews, I mean, this practice actually is not supported by multiple studies. So we have the study by Ning et al. It's a systemic review and meta-analysis regarding the use of pre-medications for the prevention, basically, of non-hemolytic transfusion reactions. And what they saw was the routine giving of pre-medications, basically acetaminophen and diphenhydramine, did not prevent non-hemolytic transfusion reactions. There's this other study by Sanders in the pediatric population, which showed no difference in reaction rates with pre-medication use. Um, Probably the best advice that we can give is better alternatives such as leukoreduction that was discussed previously, because this has proven benefit. No, actually, we advocate the use of universal leukoreduction in our blood products because it really reduces the rates or incidence of febrile non-hemolytic transfusion reactions. Also, if the patient has a history of allergic reaction or well recurrent or allergic reactions, probably it's best to use washed RBCs. And then what we can also do is have plasma reduced components for that particular patient.
Mhm.
Thank you.
I to- I
Okay.
totally agree that leukoreduction has paved the way for safer transfusion practices. No, but in your practice, do you actually give pre-medications, or to which patients would you give the pre-meds to?
Honestly, there are some patients wherein I give those pre-medications to. But when I use leukoreduced components, my residents know that I don't routinely give pre-medications if the blood products are already leukoreduced. For the pre-medications, honestly, I give them to non-leukoreduced platelet products or plasma products because these have higher incidence of having allergic or transfusion reactions. Though again, it's not really that recommended. So it's still leukoreduction. But if your
Yeah.
hospital is not capable to do all of those, um, yun.
Yeah, and also if the patient already had a prior history of an allergic event, so
Yes,
they will read the pre-medications. They would be the right group to give the pre-medications to. Okay,
agree, ma'am.
so
So
yeah,
another
and so
question for Dr.
yes,
Camille. Doctora, yes. May I know insights regarding autologous blood donation prior to elective OR?
Autologous blood donation. I think this question came from Dr. Ordonia.
Yeah. Yes.
Hi, Dr. Ardonia. Shout out, the head of the Philippine Blood Center, the director. So, Doc, Doc Dens, regarding your question on autologous blood donation, in my practice, I have already experienced this actually. We had a patient before during my fellowship training wherein she was identified to have multiple alloantibodies, red cell antibodies. So it was really difficult to find a specific blood unit for the patient who was supposed to be to undergo an operation. So we talked to the patient and the blood bank. So what we did, since it's difficult to get um, a specific blood unit for that particular patient because cross-matching will really not deem compatible blood units. So what we did was to do that autologous blood donation. So according to the American Red Cross, actually, if first of all, you need to know what surgery will be done to the patient. So the estimated blood loss, also the level of the hemoglobin of that particular patient. Swerte lang kami kasi that particular patient had good hemoglobin levels prior to the start of the surgery. Nasa 130s, 140. So talagang good candidate siya. And in terms of comorbidities and medications use, wala eh. So pasado din siya dun sa donor screening na routinely na binibigay. So what we did was to get 2 units for her kasi yung expected blood loss for her surgery was about if I'm not mistaken, around 700 to 800 cc yung binigay ng surgeon. So we did prepare her na magkaroon ng 2 units ng autologous blood, which was successfully collected. Yung sa American Red Cross, they recommend around 4 to 7 days interval before recollection. And then many physicians would prefer that the patients not have that autologous donation within 7 days of surgery. I think yun yung best na sagot doon.
Yeah, I totally agree. No, I think yung sa autologous, it has to be dapat merong planning ahead, no. But not all of the patients would actually have that luxury, no, of having those things planned ahead. There's a very interesting question. I think this is something that we have to address. Because it's a very common practice. No, I think both Dr. Camille and Dr. Rosa can answer this question, because you both kind of touched on it during your lectures. No, so good evening, doctor. For hospitals without platelet concentrates and the patient has both anemia and thrombocytopenia, can we use fresh whole blood? Because this is a it's a very, very common concern. So can you address this, please?
Sige, I'll give the first answer and then I think Doc Rosa will add some inputs also. So for fresh whole blood, as what was previously mentioned, we really advocate blood component therapy rather than giving fresh whole blood. However, in the event that there is, well, if the patient has bleeding, no, clinically bleeding, and then really talaga may pangit na yung anemia niya, symptomatic anemia, and then there's also thrombocytopathy already, bumababa na rin yung platelet count. So if fresh whole blood will be given, dapat yun ay freshly collected as much as possible. Why? Because if old na yung fresh whole blood, you have to understand that the components there will not really work anymore. Like yung platelets, when we do platelet apheresis collection or random donor collection, ang lifespan lang nun would be around 5 days. Tapos after, mag-expire na yung blood unit. So kung old na whole blood yung gagamitin, we don't really expect those components to be present any longer. So yan yung magiging parang issues doon. And then probably siguro maa-advise ko, good collaboration then with our Philippine Blood Center, kay Dr. Ordonia, he's here. So baka matulungan din po yung mga institutions na medyo with limited blood, no? I think it's a common problem for all institutions, especially sa platelets. Grabe, ang hirap talaga.
Yeah.
Yeah. Thank you.
Have anything to add?
Naka-mute po kayo, Doktora.
You're muted, Doc.
Yan.
Sorry. Okay. So I agree with what Tanchi has said. So the fresh whole blood, if not freshly collected, would have no functioning factors and platelets already. So please do not forget to always address the underlying cause. So baka naman hindi naman siya bleeding tapos kunwari dengue lang and not bleeding ganun. So or septic, if the patient is septic, so address the underlying cause instead of giving your blood products. Kung hindi available, magpapanik-panik ka pa. So just do what is accessible to you. And if talagang you need platelets, I guess with the advent of platelet pheresis, we can now easily request kami dito, here in Laguna, our Red Cross is willing to make us apheres platelets, pero we have to inform them like 24 to 48 hours before the day that is needed. So kung talagang super urgent, so maybe you can also request for an apheres platelet from your local Red Cross.
What is it in the fresh whole blood that what is the reason that we don't want to transfuse it to patients? Because there's a certain
Of course, kasi since your factors and platelets are not active anymore, so you're just actually giving extra volume that may make the patient more prone to congestion. So hindi na siya valuable.
And thank you for those clarifications. Yes, Rico, may add ka?
Yes, I would agree that as much as possible, component therapy if needed. If you are unable to source and you have really exhausted all of the possible avenues with addressing the underlying cause, then you may be warranted. But again, it's sort of a last resort, no, to give your whole blood. There's actually a new statement in the 2022 updates of the Association for the Advancement of Blood in Biotherapies, which have stated that whole blood may actually be used. No, although the statement has not yet reached widespread use. No, but it sort of gives us an inkling that we might be able to use whole blood for the same indications that we would require, for example, addition of volume together with oxygen carrying capacity. So there might be some insight to that, although we would still have to review the evidence.
Alright.
Thank you.
Thank you.
So, are there any questions, Dr. Lilibel, for Dr. Rosa? Mag-ano muna tayo, because we only have that much time left. So I think there are some questions about the HBTC. So let's address those po.
Yes, ba? Right. For Dr. Villanueva po, how far does policies cover us regarding the strict implementation of rational blood use in our hospitals? Because some attending physicians argue that their clinical decision regarding use of blood on a clinical situation is better than this place policies. Do you have some sort of punishment for this kind of situations, or do we even have to have a legal to give punishments? Well, I know that, no, kasi sometimes po, really, it's between the surgeons and the hematologist. Usually, no? Kasi the hematologists are very conservative in blood transfusion because of the possible adverse effects. And then yung surgeons won't touch the patient kasi gusto niya matransfusan ng blood, no? So what's your stand on that, Dr. Villanueva?
Okay, so thank you for that question. Actually, it's very interesting and challenging, this question is. So we will always encounter this physicians who always want to negate negate us, but meron naman siyang point, though. So we always go clinical. So sometimes there are conditions wherein even though the hemoglobin is really not that low enough based on sa new guidelines as presented by Tanchi na less than 7, so they would already present with symptoms. So of course warranted for you to give your transfusion. Pero in terms of policies, so whoever this doctor is that is asking, I think that should be an essential member of your hospital transfusion committee. Kasi when you are making your policies, so sasabay-sabay kayo that you are reviewing the indications, what are the levels, kasi yun yung authority dapat ng hospital blood transfusion committee. You will be the one who will decide on what hemoglobin threshold you will be using based on your research and latest guidelines. So in terms of legal punishment, I don't think we can punish naman, no? Because really parang defensive medicine siguro yung ginagawa din niya. So we cannot really fault him. Pero what we can really do is just try to make him realize that these policies are made based from well-researched studies, and of course with in mind na we also want to conserve blood. And yun nga, lagi ko doon sinasabi, always know the underlying cause. So if it's anemia of chronic disease, yun yung tenets of your patient blood management. So we have to reduce the use of our blood products, but instead maximize the medical management on how we can improve the hemoglobin level without the use of blood products. So invite mo yon. Yan yung sinasabi ko kanina na headhunt. So anyone who approaches you that asks you about the transfusion committee or blood transfusion, trigger mo na yon, ay, this person is interested. I'm gonna get you for my transfusion committee. Ayun, yan. So yan lang.
Dok, baka wala nang magtanong pag ganon.
Strategy.
It's already 7:02 and there's still a lot of questions in the chat box. So can we invite Rico and Dr. Camille to kindly answer na already the questions na which are targeted towards them in the chat box because we won't be able to address it anymore. So Guro, let's just have one more question for Dr. Rosa. I'll combine some questions together na po. So how often would the HBTC or how often should the HBTC convene in a meeting, and how would DOH help the HBTC become functional?
Okay, so personally, there is really no prescribed schedule on how often you want to do your HBTC. So it's up to your institution. Sa akin personally, with all the HBTCs that I handle, we only do it quarterly kasi masyado namang toxic kapag monthly. So okay na yung quarterly reports. And then if there are special cases, like for example for these tertiary hospitals, because we're gonna launch na yung aming parang learning series, so we're meeting more regularly para ma-plan siya namin all our plans. So with regard to DOH, actually it's a very hard question. So I think before DOH can help you help your HBTC become functional, you have to be self-sufficient and help yourself. Kasi talaga yung DOH is a governing body, it's a governing body with policies. So actually ang ganda nung meron naman tayong there is a guide given by the DOH based on the RA 7719. So it's included there. Ano ba yung functions ng Hospital Transfusion Committee? What is expected of them? So bilang the chairman and the member of your hospital committee, it is up to you to implement what they have already given as a guide. So yun. So I think ang hirap talaga if we ask directly from the DOH. It has to come from us.
Thank you. So for the questions in the chat box, we are sorry that you'll not be able to answer them all live, but our panelists will be answering them in the chat box. So Dr. Lilibel, it was a very interesting and informative and interactive evening for everybody, right?
Yes. So again, from a non-hematologist, I would like to thank our speakers for giving us great lectures. It's really helpful, no, for us. So may we have now our president of the Philippine College of Hematology and Transfusion Medicine to give the closing remarks for this program, Dr. Priscilla B. Kagiwa.
Hi, good evening, everyone. It is such an animated discussion, and we're lucky to have Dr. T, Dr. Villanueva, and Dr. Tanchanco. Very eloquent speakers have articulated what we should learn about this very important subject. And of course, we want to thank Dr. Baldemore, the region coordinator for the advocacy, and of course the PCP chapters of Dr. Fatma and Dr. Lilibel Ramos Salamanca. And we look forward to having more of this very interactive discussions in the future. There are so many questions that they want to ask, but of course the time is short, but we can do this at some other instance. But I would like just to have this from Dr. Dennis Dayo Ordoña, that we will initiate, as what Rico mentioned, that the guidelines was since 2011, that the stakeholders will initiate a consultative meeting on updating this deferral guideline. So Rico, you already have an assignment. Okay, thank you. Thank you, everyone. And we had also a lot of audience for tonight. I think that is this is a very popular topic. And thank you and have a good evening.
Thank you, Dr. Kagiwa, for our closing remarks. And Dr. Lilibel, it was a great evening spent with all of them. And we'd like to thank all of our participants for sharing the past 2 hours with us. So can they, Dr. Lilibel, there was a question earlier if they can see or get a copy of the videos?
Yes, our lecturers already gave their permission that they can share their lectures. So just please, you may email the PCP Secretariat at secretariat@pcp.org.ph, no? If you want to have a copy of the lectures. And of course, we can access the presentations anytime po in our Facebook page. So if you want to review the presentation once again, then you may so anything. Okay, with that, Dr. Marge.
Yes, Doctora. So in behalf of the Committee on Advocacy and in behalf of the different PCP chapters involved with the Advocacy Committee, we'd like to thank everybody for spending this evening with us about Transfusion 101. Good evening, everybody.
Internists occupy a unique role in healthcare. They are experts in a spectrum of diseases and complex illness, earning the moniker, the doctor's doctor. Internists use their vast knowledge, experience, and skill to identify the best possible treatment strategies, making them scientific puzzle solvers. They are proponents of extensive clinical research, evidence-based medicine, and continuing education, fueled by the commitment to provide high-value patient care that balances science and compassion. In 2023, the Philippine College of Physicians celebrates 70 years of excellence and service above game. Driven by passion, constancy of purpose, and prudence in internal medicine. Take part in the 53rd Annual Congress of the Philippine College of Physicians on May 7 to 10, 2023 at the Philippine International Convention Center. Together, let's revisit all that we've become and move toward all that we can be.